The session is on a 15-minute talk on assessing fluid responsiveness in the ICU, and I'm sure you will all appreciate that it's a fairly vast topic, and I will have to just rush through certain principles and certain ideas, and I'm sure most of you will be able to take up from the literature on this. Why do we need to know about the fluid responsiveness? The reason is that the commonest problem in the ICU is multi-organ dysfunction, and the multi-organ dysfunction is mediated through a state of hypoperfusion and organ dysfunction. And for a hypoperfused state, in principle, pathophysiologically, you need to understand the amount of preload which is necessary for the adequate perfusion. We know that in ICU, hypovolemia is extremely common, but at the same time, it's quite subtle, and we need to find out answers to detect the subtle hypovolemias in situations. And at the same time, we have seen documents and papers which have listed the problems associated with overzealous administration of fluids. It's not just out of overzealousness or overenthusiasm. It's out of the necessity to bring up certain hemodynamic variables that we try and give more fluids. And enough data has been gathered to show that such kind of excess fluid turns into problems. So how do we define fluid responsiveness? A patient who is fluid responsive is said to have a significant, which is more than 15% increase in cardiac output in response to a fluid challenge. This indicates that if you look at the Frank-Starling curve, and I'll come to it in a moment, then they are in the preload dependent or steep part of the curve, and the volume expansion in these patients is going to, if you add this much volume, you're going to get additional amount of stroke volume. So if the ventricles are in that steep curve, and if they are preload dependent, then only they will be able to increase the stroke volume and the cardiac output. And therefore, we need to know whether this person at this point of time is actually fluid responsive. So it's a dynamic state. And if you look at the Frank-Starling in a normal heart, and if you look at it in a failing heart, and remember that a large number of our patients in the adult intensive care units have a component of failing heart, either because of a coexistent cardiac problem, or even in septic with the myocardial amount of myocardial dysfunctions. And in the elderly population, subtle ischemic hearts also are lurking around. So we have a significant population of patients whose hearts may not be normal, and in trying to treat them, there is a range. And if you are trying to then give fluids to these patients, you need to know whether they are going to be able to erect this response in the form of an increased stroke volume, increased cardiac output, rather than just having an addition of the volume load to their heart and to produce problems related to the hypervolemic state. So in patients who are in hemorrhagic shock or with a high suspicion of septic shock in the early phase when they arrive into the ICU, there is no issue, because the clinical signs of the hemodynamic instability have a good prediction of volume responsiveness, and there is no therapeutic dilemma, because in the initial phase we are going to give them fluids in any case. So the issue doesn't come in these patients. The issues come in patients who have been there in the ICU, who are already resuscitated for several hours or several days, and now develop hemodynamic instability or continue to have hemodynamic instability, and without the certainty of volume responsiveness. So in this is a subgroup of patients where we need to have our understanding as to what we are going to treat them with in terms of further volumes or vasopressors or inotropes. So the problem is that when my hypotensive septic patients are seen in the later phases of their illness, not on the first day on presentation, how do I decide if these patients needs fluids, vasopressors or inotropes? That's the key, and that is where we are going to discuss the issue. You look at the SOAP study data from Jaloi Vincent's presentations, and you see that one of the major problems which are one of the major predictors of increasing number of deaths is increased cumulative fluid balance. So it's not a joke that we tend to give fluids and not produce a response. Doesn't matter, because cumulatively, if you add to these positive fluid balance, that may be one of the risk factors for an increasing death. So it's a serious issue, and therefore it's time that we also understand the implications of just a fluid challenge treatment in our patients. And of course, we have, all know about the FACT study, which looked at the fluid balances over a period of time in patients who are mechanical ventilation. So, ladies and gentlemen, it is important to know how to give, but not to give too much. And that's where the state of fluid responsiveness comes. Is there any role of physical examination findings? Orthostatic hypotension obviously is one of the keys in telling you that they are likely to be fluid responsive. But the supine tachycardia is a specific indicator, but a very insensitive indicator, and therefore we cannot rely on it being present as a part of the state of hypovolemia or reduced preloads. Okay, so how do we predict preload reserve and hence volume responsiveness? First, by estimating the preload. So you measure the preload and you look at CVPs and pulmonary artery wedge pressures as part of the assessment to decide whether the preload is adequate or not. And you know that these are very fallacious readings. You have all used CVP. We have all been submerged in data which tells us the inadequacy of using CVP as an indicator to tell us that the preload is adequate or not. And the latest study which came out in 2007 indicated that cardiac filling pressures are not appropriate to predict hemodynamic response to fluid challenges, because they found that even with low CVPs, the predictive value of CVP going up and the patient being fluid responsive was low, and so also the pulmonary artery wedge pressures. So to assess whether the patient is going to respond to fluid, if you measure the baseline pressures, their ability to tell you whether they are going to respond or not is limited, and therefore these measurements are limited indicators to tell you whether the preload is going to respond to the volume challenges that you are going to do. This is primarily because the assessment of preload is not the same thing as assessing the reserves. And it is possible that the reserves may have been inadequately filled despite the numbers looking okay, and therefore you give further amounts of fluids, you do see an increase in the cardiac output, you do see an increase in stroke volume, and that tells you that despite the numbers having looked adequate, the preload having looked adequate, you could improve their cardiac output that bit extra by giving that fluid, by giving the fluid. So assessment as a assessment of the current preload may not be the same as assessing what the reserve is, and therefore using dimensions like on echocardiography, and I'm sure Ram will allude more brilliantly to this. The assessment done on echocardiography will also have these kind of small limitations in terms of current preload assessment as against the possibility of responsiveness of the reserves. The next way in which you can predict the preload reserve is by using dynamic test, and that is going to be the key because it's a dynamic process. It's not going to be a static process. So if you get a static reading in the form of a CVP or a pulmonary artery wedge pressure, that's not going to tell you how the patient is going to respond at this point of time with these hemodynamics, with these pathophysiological changes. And therefore you need something which is dynamic. So people used to say serial CVPs or serial pulmonary artery wedge pressure and the way the trend is going. But unfortunately that has also been shown to be inadequate. Therefore we now have tools which are looking at dynamic tests to detect the reserves of the preload. And for using those, we are taking the help of certain physiological principles. In patients who are on mechanical ventilator, the positive pressure and the venous return have a relationship about which we all know. We know that in an adequately volume resuscitated patient, the venous return does not fall during inspiration on positive pressure ventilation, and the intrathoracic pressure and the intra-abdominal pressures are on the higher side, and therefore the pressure gradient is maintained. Whereas in patients who are volume depleted, you see a collapse of the intra-abdominal veins and the superior vena cava, and that's what we will be seeing on the echocardiography also. And therefore, by using the stroke volume and the pulse pressures to measure them, to detect whether they are going to be fluid responsive, is going to be a methodology in patients who are on mechanical ventilators. So you can see the variations in the pulse pressure as indicated here. During inspiration, you measure the maximum of the pulse pressure and the minimum and the variations in that. And these variations are good indicators to tell you whether the patient is likely to be fluid responsive or not. There are some limitations of pulse pressure interpretations in the form of the compliance of aorta being non-linear, especially in patients who have stiff arteries, the problems with damping, the problems with wave reflections because of the arterial pressure tracings, the aortic flow during systole tending to be more continuous rather than pulsatile, and so on and so forth. And these limitations are there to make an assessment of pulse pressure relationship to stroke volume. The current devices which are available to automatically analyze waveforms for stroke volume variations and pulse pressure variations include the three main standard pillars in the form of picos, lidcos, and flow tracks. And these pulse pressure variations have certain limitations and certain advantages which have been listed out in the literature. I'm sure all of you are aware of that. They are subject to confounding effects. They most of the times have some proprietary algorithms. So if you want to then inculcate this data into our practice, you need to make sure that these algorithms are appropriate. And these algorithms are proprietary, and therefore you may not be able to understand them from their hemodynamic and from their mathematical perspectives. This is basically methodologies need clinical validation, and although the industry keeps on saying that they have been validated, one needs to make sure that whatever technology one is using amongst these three, that it has been adequately validated in terms of appropriateness in the given situations. The stroke volume variations, one of the very popular systems is the flow track or the Vigilio from the Edwards Life Sciences. It's actually a multimodal monitoring system. Again, it has its own proprietary algorithms, and again there is some amount of divergent data regarding cardiac output which comes out from this system. But overall, if you compare these three modalities, PICOs, LIDCOs, and flow track, then you have its own method, its own advantages and disadvantages. And whatever system one would want to use, I think it's a good idea to get a handle on the system, knowing its limitations, knowing its positives, and then interpreting it in a careful manner in terms of the patient's clinical situation and pathophysiology, rather than blindly going on to the numbers of a given system. So there is enough data which has come out on the PICOs, LIDCOs, and flow tracks in various clinical situations, and the limitations have also been well defined. Overall, over these three systems, they are basically limited to controlled ventilation only. So they are applicable in patients who are on mechanical ventilators. They shouldn't be having major arrhythmias. Occasional ventricular ectopics are okay, but major arrhythmias should not be there. We should obviously be incorporating them into the clinical context, and the validation of the software needs to be confirmed before we make sure that we use these data. One of the interesting ones which are coming up in a non-invasive manner is the plethysmography variability index, which is interesting because it basically deals with pulse oximetry plethysmography tracings, because they are correlated with the arterial pressure tracings. So the pulse oximetry plethysmography variability is now incorporated by some systems in manufactured algorithms, and these have undergone trials, and these have shown some promising results. And if you plot the graph of the sensitivity and specificity of various tests and look at pulmonary capillary wedge pressure, CVP, cardiac index, pleth variability index, which is in the right, in the red color, then it has very good sensitivity and specificity as compared to the other systems which will be there. And finally, in patients who are not on mechanical ventilators, one of the good ways of assessing whether they are going to be fluid responsive is just a simple passive leg raising test. In the past, we used to use this in good old days as a therapeutic measure in patients who have gone in shock. Today, we use them to assess whether the patient is likely to be fluid responsive. And the way in which we assess them is to find out if there is any change in the hemodynamic status after doing a passive leg raising test. And if they show any hemodynamic test, that we know that they are likely to be fluid responsive, and then we give them a fluid challenge. This has been validated with an appropriate changes in the pulse pressure by various studies. But the issue is whether these pulse pressure tracings itself can be taken as indicators of stroke volume, and therefore people have now started using them to assess the actual cardiac output state by doing this, and this has come out to be validated. So passive leg raising does predict fluid responsiveness in critically ill non-ventilated patients with changes documented in the blood flow as well as cardiac output. So in conclusion, ladies and gentlemen, in spontaneously breathing patients, prediction of volume responsiveness is a difficult issue. The valuable indicators are the response to passive leg raising and inspiratory decrease in the right atrial pressures. But overall, if you look at the conclusions from the available material for the fluid responsiveness test, we need to define the fluid responsiveness in most of our ICU patients at some point of time. They are different on mechanical ventilator and on spontaneous breathing. PLR is good when spontaneous breathing. On mechanical ventilators, various modalities are available with reasonable efficacy. You need to make sure that you understand your modality and conquer it by understanding it appropriately with its limitations. And finally, a carefully conducted fluid challenge may be the one which will give you a definitive answer. So the test will tell you that this is likely to be a fluid responsive. So you finally got to give it in a careful manner, limited amounts with defined targets, and see whether he responds or not. Thank you very much.